Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 467 of our pharmacotherapy series, which majors in adult hematologic malignancies. The next case reads, BBC is a 62-year-old, otherwise healthy man who presents with acute back pain after performing light maintenance work. He was initially prescribed non-steroidal anti-inflammatory drugs, abbreviated as NSAIDs, but has achieved little relief. Computed tomography (CT) scan of the spine reveals osteolytic bone lesions from T6 to T11. Further workup reveals a hemoglobin of 7 grams per deciliter, serum calcium of 11.8 mg per deciliter, and serum creatinine of 1.9 mg per deciliter. Serum and urine protein electrophoresis reveals M protein typed as IgG kappa of 5.3 grams per deciliter. A serum beta-2 microglobulin was 4.4 mg per liter. Bone marrow biopsy reveals 90% plasma cells, and cytogenetics reveal that he has AT4/14 translocation. Skeletal survey shows additional lesions in the ribs. A diagnosis of multiple myeloma, abbreviated as Stage 2, is made. Is this presentation consistent with the diagnosis of multiple myeloma? BBC presents with a number of the classic features of multiple myeloma. Bone pain and skeletal disease are common and occur when plasma cells infiltrate the bone marrow and secrete osteoclast-activating factors. Plain radiographic films will reveal osteopenia or multiple osteolytic bone lesions. Patients with smoldering multiple myeloma should have more extensive imaging scans done with magnetic resonance imaging, positron emission tomography, PET, and/or CT, to help determine the presence of multiple myeloma bone lesions. Hypercalcemia and pathologic fractures often accompany the osteolytic lesions. When plasma cells infiltrate the bone marrow, they can also lead to anormocytic normochromic anemia in up to 70% of patients, although neutropenia and thrombocytopenia are relatively rare. Renal dysfunction is generally attributable to deposition of kappa or lambda-like chains of immunoglobulin in the distal tubule, and up to 40% of patients have or will develop renal insufficiency with the disease. Renal dysfunction can be further complicated by dehydration secondary to hypercalcemia, the use of non-steroidal anti-inflammatory drugs, and the use of contrast dyes in radiographic evaluation. BBC should receive hydration to restore euvolemia and reduce his calcium. He should avoid non-steroidal anti-inflammatory drugs and other nephrotoxic therapies. Excessive immunoglobulin production may also cause hyperviscosity syndrome. which may lead to CNS, renal, cardiac, or pulmonary symptoms. Plasmapheresis may be used to alleviate life-threatening cases. Patients may experience recurrent infections as a result of depressed production of other immunoglobulin classes, leading to an inability to opsonize bacteria. BBC clearly meets the criteria for multiple myeloma. Two staging systems have been used for patients with multiple myeloma. The older Jury-Salmon system, developed in 1975, and the newer International Staging System, abbreviated as ISS. The International Staging System was validated in a large international study demonstrating that prognosis can be predicted reliably from serum beta-2 microglobulin, a light chain protein expressed on all nucleated cells, and albumin. Based on the International Staging System, BBC has Stage 2 multiple myeloma. Further classifying patients as having standard or high-risk disease based on cytogenetic markers can also help determine a patient's prognosis and help guide treatment decisions. Next we will discuss treatment. Let's consider initial therapy. Patients with multiple myeloma are candidates for systemic chemotherapy. The most effective treatment is induction followed by autologous hematopoietic cell transplantation. Therefore, eligibility for hematopoietic cell transplantation helps determine the most appropriate treatment option. Determination of hematopoietic cell transplantation eligibility includes consideration of patient age, typically 65 years of age or younger, and comorbidities. In the case of BBC, his age, that is 62 years, and relative good health make him a candidate for further consideration of hematopoietic cell transplantation as a component of his multiple myeloma management. Those who are eligible for hematopoietic cell transplantation should not be treated with agents such as melphalan, which may compromise the ability to collect a sufficient number of hematopoietic stem cells necessary to perform the autologous hematopoietic cell transplantation. More aggressive three-drug combination regimens may be advantageous in high-risk patients to help increase the chance of developing a CR. The decision is made to begin BBC on treatment with a regimen including bortezomib, lenalidomide, and dexamethasone. So my question to you reads: what advantages and disadvantages does this regimen have compared with others? The proteasome inhibitor bortezomib acts by inhibiting the 26S proteasome, a multi-enzyme complex responsible for regulation of proteins that promote cell survival, stimulate growth, and reduce susceptibility to programmed cell death. Bortezomib is commonly used in combination with thalidomide, lenalidomide, cyclophosphamide, and/or dexamethasone. Patients should be monitored for common adverse events, including fatigue, diarrhea, mild nausea, thrombocytopenia, and peripheral neuropathy, the most common cause of discontinuation of bortezomib in clinical trials. Subcutaneous administration significantly reduces the incidence of neuropathy and may be a preferred route for many patients. Reactivation of herpes zoster has been observed in greater than 10% of patients treated with bortezomib. Therefore, concomitant antiviral prophylaxis should be utilized. An additional benefit of bortezomib is the ability to induce responses in patients with del(13) and T(4)14. BBC has the T(4)14 and would benefit from the use of bortezomib. Thalidomide and lenalidomide are immunomodulatory drugs abbreviated as IMIDs, commonly used in the initial treatment of multiple myeloma. They possess complex anti-angiogenic, anti-inflammatory, and immunomodulatory properties that make them active in multiple myeloma. Common adverse effects of lenalidomide include hematologic toxicities, muscle weakness, fatigue, and rash. Several studies have also revealed a small but concerning risk of secondary malignancies, which may be associated with combined oral melphalan use. Although this concern should not prohibit the use of lenalidomide, patients should be made aware of this risk. In comparison with lenalidomide, thalidomide is less potent and has a less favorable toxicity profile, with sedation and peripheral neuropathy being common in addition to constipation. Both thalidomide and lenalidomide have a risk of thromboembolism, and venous thrombotic embolism prophylaxis is recommended. Thalidomide and lenalidomide are only available via a restricted access prescription programs due to the risk of teratogenicity. Dexamethasone is an active treatment option for multiple myeloma, mostly used in combination regimens. It does have significant adverse effects, including hyperglycemia, insomnia, and increased infection risk. Although response rates are increased with higher doses, lower doses are often more beneficial. When combined with lenalidomide, low-dose dexamethasone, 120 mg, cycle, improved 1-year overall survival compared to high-dose dexamethasone, that is 480 mg per cycle, 96% versus 87%, with a p-value equal to 0.0002. Several 2 or 3 drug combination regimens are effective and appropriate for the initial treatment of multiple myeloma. The combination of lenalidomide, bortezomib, and dexamethasone, abbreviated as RVD, has demonstrated response rates up to 100% in patients with newly diagnosed multiple myeloma and is well tolerated, with sensory neuropathy, fatigue, and hematologic toxicities being the most commonly reported. The most current National Comprehensive Cancer Network, NCCN, Clinical Practice Guidelines in Oncology, NCCN Guidelines, recommend lenalidomide, bortezomib, and dexamethasone as a preferred initial induction therapy option, along with several other regimens. Independent of the choice of induction regimen, patients commonly receive 3 to 6 cycles of treatment before HCT. In patients ineligible for autologous HCT, melphalan-based regimens are appropriate for induction therapy. Melphalan and prednisone, abbreviated as MP, melphalan and prednisone combined with either bortezomib, abbreviated as MPB, thalidomide, abbreviated as MPT, or lenalidomide, abbreviated as MPR, have all been proven to be more effective than melphalan and prednisone alone. The melphalan and prednisone thalidomide regimen may have limited utility due to the increased risk of toxicities compared to melphalan and prednisone, including thromboembolism, neuropathy, constipation, and infection. In addition to melphalan-based regimens, lenalidomide plus low-dose dexamethasone or bortezomib plus dexamethasone are also considered preferred initial induction therapy options for transplant-ineligible multiple myeloma. Next we will discuss hematopoietic cell transplantation. Efforts to improve the outcome of multiple myeloma treatment have led to the investigation of high-dose chemotherapy, e.g., melphalan 200 mg per meter squared, with autologous hematopoietic cell transplantation. Randomized comparisons of autologous hematopoietic cell transplantation and conventional chemotherapy in previously untreated patients demonstrated higher response rates and improved survival in patients assigned to receive autologous hematopoietic cell transplantation. Younger age, chemo-sensitive disease, and fewer pre-transplant therapies have emerged as important predictive factors for response to autologous hematopoietic cell transplantation. Currently, autologous hematopoietic cell transplantation is considered an integral component of the overall treatment of multiple myeloma and should be performed in conjunction with induction therapy in eligible patients. The use of allogeneic hematopoietic cell transplantation in multiple myeloma is a potentially curative option, although it has shown mixed results and is often associated with excessive morbidity and mortality. BBC will receive 3 cycles of lenalidomide, bortezomib, and dexamethasone and will be evaluated for hematopoietic cell transplantation. Zoledronic acid 4 mg IV over 15 minutes every 28 days is ordered for BBC. What is the rationale for bisphosphonate therapy in the presence of normal serum calcium? What benefits and toxicities are associated with bisphosphonate therapy? Osteolytic bone lesions or osteopenia occurs in nearly 80% of all patients with multiple myeloma and represents one of the most significant challenges to quality of life in this patient population. Although the bone manifestations of multiple myeloma may occur throughout the body, they are most commonly identified in the vertebral column, where they may lead to clinically significant issues, including fracture. The efficacy of pamidronate and zoledronic acid for the prevention of skeletal-related events and improvement in overall survival has been established in multiple myeloma patients, irrespective of the presence of osteolytic bone lesions. Equivalent efficacy with monthly infusions has been shown with pamidronate and zoledronic acid. Because bisphosphonates can negatively affect kidney function, serum creatinine should be monitored monthly and treatment should be held if creatinine increases by more than 0.5 mg per deciliter above baseline. Higher doses and shorter infusion times have been associated with renal damage. Patients with creatinine clearances between 30 and 60 ml per minute should receive reduced doses of zoledronic acid, and pamidronate over 4 to 6 hours is recommended if the creatinine is more than 3 mg per deciliter. Osteonecrosis of the jaw, abbreviated as ONJ, is a rare but serious complication of bisphosphonate therapy. Zoledronic acid is associated with a 9.5-fold increased risk of osteonecrosis of the jaw compared with pamidronate. Baseline dental examinations and avoidance of invasive dental procedures during therapy are recommended. All patients with responsive or stable disease should be strongly considered for bisphosphonate discontinuation after 2 years of treatment. Denosumab is a monoclonal antibody that binds to rank ligand, which results in decreased osteoclast function and a reduction in bone resorption and bone destruction. Although the efficacy and side effect profile of denosumab are appealing, it cannot be recommended at this time to replace bisphosphonates in the management of multiple myeloma patients because of an increased risk of mortality observed in a planned subgroup analysis. BBC is a candidate for bisphosphonate therapy because he has symptomatic multiple myeloma and osteolytic disease in the spine and ribs. BBC receives 3 cycles of lenalidomide, bortezomib, and dexamethasone, followed by autologous hematopoietic cell transplantation. He returns to clinic today 8 weeks after hematopoietic cell transplantation. Should he receive any additional treatment at this time? Given the near certainty that multiple myeloma will progress after autologous hematopoietic cell transplantation, maintenance therapies are utilized to extend the duration of response. Two phase 3 studies have evaluated the benefit of lenalidomide in this setting. In the CALGB 100104 and IFM 2005-02 studies, lenalidomide 10 to 15 mg per day significantly improved progression-free survival, with the CALGB study also demonstrating an overall survival advantage. Although thalidomide has also demonstrated some efficacy as maintenance therapy, its side effect profile limits its use long-term. Therefore, lenalidomide may be preferred as a result of its improved toxicity profile, although the risk of secondary malignancies should be discussed with patients. Bortezomib has also shown efficacy in the maintenance setting. Compared with thalidomide, bortezomib, at a dose of 1.3 mg per meter squared every 2 weeks, significantly improved progression-free survival and overall survival. Although neuropathy is a long-term toxicity that may limit its use in some patients, bortezomib may be considered a treatment option in the maintenance setting as well. The decision was made that BBC would receive maintenance therapy with lenalidomide 10 mg daily until disease progression was documented. 4 years after autologous hematopoietic cell transplantation, BBC is found to have relapsed disease. So my question to you reads: what other therapies may offer benefit for his myeloma? The number of treatment options for relapsed or refractory multiple myeloma is continuing to grow. When deciding on treatment, many factors need to be taken into consideration, such as chromosomal abnormalities, prior regimen exposure and toxicities, response to prior regimens, and comorbidities. For patients presenting with relapsed multiple myeloma more than 6 months after initial induction therapy, it is reasonable to retreat using the same regimen. For those patients with early relapse or refractory multiple myeloma, bortezomib or lenalidomide-containing regimens are acceptable options. When either of these agents was studied in combination with dexamethasone, they demonstrated significantly improved time to progression and overall survival compared to dexamethasone alone. Bortezomib may also be combined with pegylated liposomal doxorubicin as an effective salvage regimen, with cytopenias, diarrhea, and fatigue being common toxicities. Carfilzomib and pomalidomide are two newer agents, both approved in the relapsed or refractory setting with ongoing studies as initial therapy options. Carfilzomib is a proteasome inhibitor that binds irreversibly and more selectively than bortezomib, leading to decreased neuropathy and activity in some bortezomib-resistant patients. Common adverse effects include fatigue, anemia, nausea, and thrombocytopenia. Peripheral neuropathy occurs in 12.4% of patients, with only 1.1% being grade 3 or higher. Carfilzomib also has significant efficacy when combined with lenalidomide and dexamethasone, as demonstrated in the Phase 3 ASPIRE trial. Dexamethasone premedication is recommended with each dose during cycle 1 and with any dose increase due to the risk of infusion reactions. Hydration is also recommended with each dose during cycle 1 to decrease the risk of tumor lysis syndrome. Pomalidomide is the new IMiD, structurally similar to thalidomide and lenalidomide. Phase 2 and 3 trials have demonstrated significant activity and a manageable toxicity profile when used with or without dexamethasone in the relapsed or refractory setting. Pomalidomide is dosed at 4 mg daily for 21 days of each 28-day cycle, although lower doses may be effective. Myelosuppression is the most common toxicity. The histone deacetylase inhibitor, panobinostat, has also been approved for use in the relapsed and refractory setting in combination with bortezomib and dexamethasone based on the favorable result of the Phase 3 Panorama 1 trial. Side effects, including cytopenias, diarrhea, and peripheral neuropathy, may limit the use of panobinostat. The NCCN considers a variety of combinations as preferred regimens for the management of patients with relapsed or refractory multiple myeloma. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 468.